And so this is actually a really unique event today. We're blessed to have two physicians, Dr. John Pietrafesa, psychologist and a specialty in sexual dysfunction, and I'll have him do some introduction in just a moment. Dr. Jason Hafron, who's a physician at the Michigan Institute of Urology, specialty in prostate cancer, minimally invasive laparoscopic robotic surgery, and also chairs our cancer committee at the Michigan Institute of Urology. So just because you're here today, that means already you should be an expert. But also the question is I'm going to put this one to, since Jason is a microphone, I'll start with Jason. What is it that made you decide that prostate cancer was something that was so important to you that you decided that that had to be the focus of your career?
That's a good question. I get asked this a lot as friends and family, like, why urology? Why did you want to, that's the last field I would have gone into. And I'd say there's two things that stand out. One is the technology. Urology has always been a leader in minimally invasive surgery. We were the first specialty to bring in robotic surgery, one of the first specialties to bring in laparoscopic. So that's what started me initially, made me gravitate towards urology, was the awesome technology that we have to treat these diseases. But then as I got further along, I subspecialized into cancer, and specifically prostate cancer, because not only is it a disease where we can make an impact and we can cure most of the men that we treat, but also it has affected my family personally. So I've been through it on both sides. I've counseled my father-in-law is a prostate cancer survivor. And this was early in my career where I realized it. So I see both sides of it, and that's kind of seen my father-in-law go through it and my grandfather go through it. I kind of get it, and I understand from a medical side, but also from a personal side, what it is to get a Lupron shot, what it is to go through surgery, and how to talk to, wife, sister, brother, whoever it is, and it just came very easy for me, and that's why, I'm where I am today, and where I'm excited about the future. There's a lot of good things coming.
Well, I hope you can all feel Jason's passion, but we haven't yet experienced John's passion. And I've known John Pietrafesa now for probably about 15, almost 20 years now. And I just think it's important to tell people, what is a psychologist? How is a psychologist different from a psychiatrist? Because people make that confusion all the time. And how did you choose your area of interest? And how does that really play into what you think, looking at men down the road?
I think that's a good question. Let me start with probably the basic one. The difference between the psychiatrist and the psychologist. Psychiatrists prescribe medications, whereas the psychologists do not. Much of what's going on in psychiatry is movement toward medication management, where psychologists deal more with the therapeutic aspects and working with couples and individuals. How it developed it's kind of interesting. Actually, I loved history the best, and I wanted to go into history. And when I got to my senior year to go into grad school, the one fellowship I wanted, which was a national one, did not materialize, but they offered me fellowships in psychology. And since I always enjoyed studying or working with people, that's what we did. How it came into sexuality, actually I'm a professor at Wayne State University. I think I was the youngest professor ever hired there, and I've been there 50 years now, so I've been there a very long period of time. In my many years back in the 60s at a terminal class, one of the students said, we really like this program, but I'm really a little nervous going out to work with clients because no one's ever mentioned sex or sexuality in any of my classes. So I put into place at the university the first sexuality classes that were available for counselors and social workers, psychologists, and so on. And I don't know if you remember Mario Petrini, but Mario would come to my classes and also work. He taught the sexuality at the med school. So that's how it developed. And over the years, worked with a number of recovering patients who have had sexual difficulties and trying to work with couples and work through that.
Well, I'm happy to say that 50 years at the university truly antedates even me. So I'm happy to say that. So one of the things that is most often talked about now in prostate cancer is active surveillance. And I am assuming that probably all the prostate cancer survivors here are not members of the active surveillance category. And I would actually be surprised if you were, only in the sense that active surveillance is something that hasn't really been talked about, and really embraced until the last couple of years. The talk was there maybe 5 or 10 years ago, but the embracing of it hasn't really come to fruition. And it's really interesting that these two people, our two experts today, are really going to be interesting in the sense that active surveillance is not only the perhaps either delay in treatment or non-treatment, but it's also how does that impact you psychologically? How does a man psychologically deal with the concept of not treating their cancer? You have to realize that active surveillance for prostate cancer is more or less the leading edge in active surveillance for all cancers in the human body that are potential candidates for it, and prostate cancer is not the only one. It's the one that we talk about now, but other cancers such as ovarian cancer, lung cancer, breast cancer, believe it or not, are all going to be potential candidates for active surveillance based on some of the newer technologies that are also being used in the genomics and metabolomics as we move forward. And so I think I'd first like to have Jason talk about how do you determine candidacy for active surveillance, and what is the role of active surveillance, and how do we educate and change our community?
Those are all great questions. Active surveillance is not a new idea. It's something we've had for many years. Right now, 90% of all prostate cancer is being treated in the U.S. And what we've struggled with is which cancers can we watch or survey, and which cancers do we have to treat. And most recently, there's been major changes or the start of new changes in how we evaluate prostate cancer. Through Michigan Institute of Urology, about 2 years ago, we committed ourselves to evaluating these new biomarkers. Biomarkers are new analytics, or new ways to look at tissue to determine, is this cancer going to kill me? Is this cancer going to spread? Do we have to treat this patient? And we've been involved with many projects through MIU, or Michigan Institute of Urology, to answer that question. And we have a few that are on the market today. We are also working with a company out of Boston to look at this as well and develop our ability. Basically, the question we need to answer is this prostate cancer going to kill this man? And we are getting to the point now where we are able to predict with higher precision which cancers are the deadly cancers and which are the cancers you can live with. I have this discussion probably 5 or 6 times a day throughout my week and consult many patients, and I can show them a stack of literature or show them 100 studies saying that this cancer you'll probably be fine with. I can't guarantee anything, we're not there yet, but hopefully we'll get there. But what Dr. Lutz alluded to is that even though I can show you a stack of literature saying you're going to be fine, there's a huge psychological component to this, because a lot of patients will say, Doc, I don't care what all that literature says. I want it out. I want to treat it. I know my friend down the street, my uncle or whoever, had prostate cancer, and this is what happened to him. I'm not even going there. You can stop your discussion now. Just treat me. And I think that's part of it too. So I think with prostate cancer treatments, you need to adjust to the psychology of the patient, what the patient's looking for. So it doesn't matter that you have the ability to predict it. Some people can't sleep at night knowing they have a cancer that's not being treated. And I think that's important is to develop a treatment plan with the patient that will allow them to move on with their life. Whether it's getting out, whether it's taking the prostate out, radiating the patient, or following the prostate cancer, whatever works for that patient and is medically reasonable is important.
Do you base that on after the biopsies are done and based on the Gleason scores?
That's a very good question, yes. But when we evaluate a patient for surveillance, we look at PSA Gleason score, and now we do a couple additional things that we've just started to utilize. One is we may consider an MRI. We have a special MRI, multi-parametric MRI, that can evaluate for prostate cancer. One thing Dr. Lutz has spearheaded within our group is a 3D mapping, where we'll actually do biopsies, cover the entire gland. And what I was alluding to is we have molecular markers, these send-out tests, that will look at the DNA within those cancer cells and determine if it's a bad player. So it's a combination of all of what I just said will help us predict or guide our patient's treatment. So and this has only been in the last 2 years, so we've made major strides. And again, what we're trying to do is simply is how good or bad is this cancer? Because what we've been using for the last few years is good, but now we have better. And that's where the art of medicine comes in. You know, an 84-year-old man with aggressive prostate cancer, I don't know his Gleason, I don't know his PSA, even though he's 84, what we want to look at is quality of life. We don't want that your father to experience any side effects related to the cancer. Do we have to treat him, or can we follow it? And it's a tough question. But again, you personalize it to each patient. So an 84-year-old man, would I recommend surgery? No. You know, would I treat him? Possibly. You know.
Give him the anti-hormone and then the
Avodart. Yeah, so he's doing a primary hormonal treatment, which is probably adequate in a guy his age. It's not going to cure his cancer, but at the same time, he hopefully will never have any side effects related to his cancer, and not to be crude, but it passed from something else, not the cancer itself.
So just to elaborate a little bit on the psychological component that Dr. Heffron touched on is are there things that we can look at to be better physicians, to analyze our patients and try and assess how they would deal with the psychological impact of surveillance versus intervention? And are there warning signs that certain patients are absolutely never to be candidates for surveillance, so that we don't even spend anybody's time going down that road?
Yeah, I'm not sure we're as far advanced psychologically in terms of the advanced the surveillance, but there are two things and a third I think that are important. One is the assessment that the person is high in terms of initiative. High initiative, high assertiveness are the two things I think in terms of self-care. The third thing I think is spousal involvement. Because I think part of it has to do with the sex roles that men and women have learned over the years. And this goes back 50, 60 years. I think it's getting better, but it's still present. Men are far less sensitive to themselves and a willingness to seek medical help. I think a lot of times it's the spouse who's saying, you need to go see Dr. So-and-so. And so I think those three factors are probably the ones in terms of psychological involvement in terms of the active surveillance.
I'm actually so glad you hit on that, because we know that oftentimes getting men to see the doctor is really not the man himself, it's their spouse that's actually driving the bus. And we don't do a good job as urologists in general of understanding that, and we as physicians in general are not really cognizant of the role of the spouse and taking care of. When we look at survivorship, if you'll look at everything that we do through the foundation as far as survivorship, everything we do is aimed at the family, is aimed at the spouse, the significant others, the children. And it's even more interesting, and the reason that this is exceptionally important is what we call epigenetic effects. And that's a new expression that's been actually applied, saying that something that your father did and even your grandfather did could have genetic impact in your life. That's passed on epigenetically. It's not even in the chromosomal material directly, but it's attached to the chromosomal material. And so it can't be measured, it can't be found. And so we're now finding things that are happening in children and grandchildren that really weren't measurable impacts. Those are the epigenetic effects or field effects. And so now we understand that this is really important. So the role of understanding survivorship is not just survivor of the individual, it's survivor of the family. And so our foundation's goal is survivorship for the family. And so that's why it's really nice to see spouses here today, because we understand the importance and the role that you have in supporting each other. And so to get this elephant out of the room, I'm not talking about anybody who's overweight, I'm talking about sexuality. And the reason that's important is because a lot of men will either avoid any prostate evaluation or avoid even having treatment for their prostate is because of the sexual ramifications. And it's probably one of the strongest reasons why active surveillance has a really good role, because it can help maintain one's sexuality during their youthful prime and be treated at a later time in life when sexuality may have a lesser or less impactful role. So from your perspective, John, this is it, is like, how do we try and get the message of sexuality, and how do we like look at it more appropriately and put it on a playing field that has a clinical significance for men when they're diagnosed with prostate cancer, not let it be totally dismissed?
You know, I think one of the things, and we try to talk to the people we're training, that it's important that the therapists or the psychologists or the physicians raise that as an issue. Oftentimes when couples come into therapy, what we see is the wife generates that. But I find that over the years that, especially with younger men these days, Once they're into therapy, they're very much open to it because I think they do respond well to being able to share some of the concerns and some of the problems with that. But I think some of the initial bringing up of this subject, because it's so sensitive to many men, they see it in terms of their manhood, if you want to call it that, that it oftentimes is not brought up, particularly, I think, if I'll be honest with the physicians, if the physicians don't raise that issue with them when they come in to seek some help.
And so, Dr. Hafron, John and I were actually talking before you got here, so we actually enjoyed this conversation. And one of the issues he brought up is something that I think you would be very aware of, is that all around the country when urologists have discussions with their patients, the statistical information they tell their patients about the sexuality outcomes afterwards are so skewed and so varied that there's almost no norm. There's almost no resource to tell them that this is a legitimate outcome or an illegitimate outcome. How do you deal with that, and what do you think is a great resource for people to understand that important part of their lives after treatment?
I think that's an important point because as a robotic surgeon, we struggle to report our results, to say what is an adequate outcome. We try to use questionnaires, we try to evaluate the spouse or the partner, and our data is not always predictive or clear. And when I sit down and consult a patient, I know what my potency rate is, I know the statistics, and I run through the numbers, but I said, honestly, this is really probably what's going to happen. In reality, we can go through the numbers, but, your sexual function will be affected. The way that you have sex or sexual relationships will be different following treatment, whether it's surgery, radiation, cryotherapy, anything that you do will be affected. The nice thing is that we have a variety of different treatment and different options to work with, and it's nice that when the spouse shows up that she can be a partner with this, but your sexual relationship will change. How much it will change, it depends on where the guy's starting, his age, and a variety of other factors, but I think the key point is that I stress that it will change and that you need your spouse to be supportive of this and that we have resources to help you in the long run. And a quote I use a lot is that, because I consult patients from 40 to 80 years old on sexual relationships, is that as you age, your sexual relationship won't be like you see in the movies, won't be like when you're a newlywed, may not revolve around intercourse, may not revolve around a hard penis. And there's other aspects of sex that are probably more important than, intercourse and a hard penis. And I get right up to these guys and tell them that, and I think that's important because there is a lot of marketing going on in medical treatments that I think misleads patients. And, doing this surgery day in and day out and treating these patients day in and day out, there's nothing worse than a patient we don't meet his expectations, who's not aware of the potential side effects. And to me, I do enough of these treatments that I'd rather have an informed patient, rather have that patient know exactly what they're in for and what to expect, than to have a patient that is unhappy or feels like this wasn't explained to him. And I think what I try to do is get away from the statistics because I know the statistics are flawed, and I just try to tell them that there will be changes, and I can get more detailed based on age and comorbidities, but just stress that it will be affected, regardless of what you do.
There's no question there's been an evolution in the treatment, and the evolution is the fact that back when I first started doing radical prostatectomies in the 80s, and we started with the nerve-sparing modification as from Johns Hopkins, we would wait anywhere up to a year before we'd intervene in improving one's sexuality. We would not do anything. We would say, it takes up to a year, we're just going to wait the year. We literally would have men wait for a year before we would do anything or address sexuality. And now it's different. How is it so different?
Now we're very aggressive. We have at Michigan Institute of Urology, we have a whole program, a penile rehabilitation program, where we have dedicated nurse practitioners and nurses that will work with our patients, and they start a few weeks after surgery or a few weeks even after radiation treatments. We'll aggressively treat these patients. And it's the same concept as knee surgery. If you were to have knee surgery, have a scope, or have a knee replacement, you're going to be in physical therapy a week or two later. The same principles apply to penile rehabilitation, where we want to get the nerves and the blood flow back into the area of injury and start treating this. So within a matter of weeks, we have these guys in our penile rehabilitation program working with our nursing staff and getting things going again. And we see great results. And it also kind of what John alluded to, kind of draws these guys in to be in touch with their bodies, because there is, I always say this day in and day out, guys are terrible patients, but if we can, get them more in tune with themselves and draw in that partner as well, it leads to, better patient satisfaction.
So one thing I don't think I've ever addressed, and because John's here, you're just in my face right now, so for me to ignore this is like crazy, is what would you do as a psychologist if we sent somebody to you right after the surgery? What would be your role when a man is recovering from any treatment or intervention for their prostate cancer?
I think this is wonderful, what I just heard too, because over the years we've seen a lot. Another area we deal with is addictions, and or I deal with alcoholism, for example, and getting into recovery. The old rule used to be that the recovering alcoholic didn't deal with the marriage or the relationship until at least a year afterwards. What we found over a number of years is by the time psychologists or treatment facilities dealt with it, a divorce was in process already. That there has to be addressing some of this issue, the sexual issues, as well as the relationship issues, which go into the recovery from the surgery, let's say, almost immediately. So one of the things we see oftentimes is within a couple of weeks to start to deal with the relationship qualities. One of the things early on that's dealt with is the sensual focus, the sensate focus, the quality of the relationship, being close, enjoying the moment. One of the things I'll often say to couples, and they enjoy this, is to eroticize the relationship in ways and terms that the couple's comfortable with. It was many years ago, this is way back in the 70s now, when I was working with Masters and Johnson for a short period of time. An 80-year-old gal came in to see Dr. Masters. And there was one-way vision mirrors, and so there were some of us were observing it. And she said, look, I've just met a new man. It had nothing to do with prostate surgery. And he's asking me to do some things I've never done before in my 60-year marriage. And she said, what should I do? And he looked at her, he said, look, you're 80 years old. What do you got to lose? Giving her permission to go ahead and try to focus more on just the sensual nature of the relationship between the couple. So that starts very early. And then over a period of several weeks, there are homework assignments that they can do that helps develop the sensual focus and and the building and the strengthening of the relationship.
How many men who are here today, I know I'm going to get to you one side, how many men are here today would actually see a psychologist after their prostate cancer intervention? Anybody? Or would you be kind of intimidated, like the thought is like, I don't go to a psychologist, that'd be a sign of weakness? You'd consider it? You'd consider it?
I didn't know I should. That's
I'm having the epiphany right now.
Yeah,
I mean, I'm just like, for the first time in my career, I'm having this one moment where I'm thinking, this is an absolutely fantastic role for a psychologist as part of the recovery process, because it would actually help bring everything together. And I don't know about you, but
No, I feel the same way. I was like, why don't incorporate the psychological aspects in the penile rehab program? We're so focused on the medicine or the function that obviously there is changes going on that are beyond the function, and the changes that will probably help the couple or the relationship adapt better and enhance the recovery process.
it should really happen before the surgery, too, frankly.
True.
That's-
Right. And
I had surgery and radiation, and was I think I want to say I was misled, but maybe not. They gave me pills and all that. Yeah, and so
I think you're the norm. Yeah. And I think it's important just in the sense that, for example, with penile implants, I have one, he hasn't been able to get an erection in the 2 years, so he's moving towards that penile implant. But he comes in with his wife. She's got to be, I think, very importantly, a part of that process and acceptance. And it's worked out very well in terms of her acceptance of his movement in that direction.
You were talking earlier about 2 minutes ago about the penile rehabilitation, like 2 weeks after surgery. When did this come into play? Like, when was that developed?
It's
How long ago? Was this like a year ago?
pretty recent. I mean, we've started getting more and more aggressive over time.
Like, well, I mean,
I don't have exact. I'm not sure exactly the exact start date of when it occurred, but you know, the general concept is the earlier we get involved, the better we'll be.
We were never, ever informed.
Well, but you know, it's hard to, you know, draw things with broad strokes. You know, not every case is the same, and people are treated differently.
Ours unfortunately was not done through MIU. Was not.
So
Referred to somebody else.
it's you know, and it's not to whoever, you know, the other wherever it was treated. It's just different philosophies of treatment. You know, me personally, I'm very aggressive. We get involved. We know these patients are out there, and you know, and we focus on that. And I think, you know, we could do a better job with our psychological component, because what I stress to my patients is, you know, it's not all about the hard penis. It's not all about intercourse. As you mature, as you age, you know, you're not, I say this to these guys all day long, you're not newlyweds. You know, this isn't like the movies. Most people your age aren't having sex like the movies. It's about having a relationship, a sexual relationship that goes beyond intercourse. You know, and I think as urologists, we're caught up in these numbers and our rigidity score and all these, you know, functional things, but in reality, it's probably function is good. You know, don't get me wrong, but function is just one small part of the whole process.
It is really amazing how, if you were to look at all the pharmaceutical industry and look at all of their slide sets, whether it be Pfizer for Viagra or Lilly for Cialis or Exilium for Stendra, every single slide set looks at measuring the rigidity of the erection as a successful outcome. So there's no question that it's being driven by another force that just doesn't really get it. And so you can get caught up in that phenomenon, and that's really where the mistake is. If you look at the statistical incidence of erectile dysfunction, it's actually a really easy one to remember because it's from the Massachusetts Male Aging Study, the largest study of its kind, where it's 50% incidence in 50-year-olds, 60 and 60-year-olds, 70% incidence in 70-year-olds. So that's a pretty easy number to remember in your head if you're wondering what the incidence of men your parallel age around you are suffering from erectile dysfunction. So
Michael, is that people who have gone?
general population, just general population, it's a pretty high incidence.
That's a high number.
Exactly, and so you have to understand that going in. So now when Dr. Hafron sees patients, in the back of his head, he goes, okay, so this is the standard population. Now I'm about to inflict something else upon them, and we have to try and figure out how we're going to get through this.
Right. You know, aging is probably the greatest risk for erectile dysfunction. You know, as men get older, and the decline in erectile function starts about age 30. So I think that men have unreasonable expectations. You know, when you consult a patient, like, do a lot of guys my age have this problem? I said, yeah. Majority of your guys, your friends, are taking these pills at some point in their lives on a regular basis. Problem is, guys don't talk about it. Women, they'll be talking all day. They'll ask their girlfriend, ask their sister, and they'll be, you know, going back and forth. Guys won't mention it. You know, you go out, you know, play a round of golf with your buddies, or go out and meet your buddies. These guys aren't going to share their Viagra stories. You know, because it's just a societal thing. There's a sense of shame associated with it. That's to males' detriment, because if males knew that most of their buddies were being treated for ED, they probably, you know, it wouldn't be such a emotional thing for them.
Let me add to in defense of age, okay, because I'm seeing some slight changes recently too. I think obviously as we get older, the relationship also changes for men. There's much more focus on holding each other, being sensual, and not so much necessarily on ejaculation and orgasm. So that in terms of the quality of the relationship, that's important. But one of the things we're seeing now, and I see a good deal, is because of the economic stressors and some of the other stressors, there's a lot more of erective distress and sexual distress among younger people too. I'm seeing it as early as 20, 25, 30s with couples who who have sex once a year. Kathy had one come in, said that they hadn't had sex in 3 years. This was a 30-year-old couple. But the stress in terms of raising children and the financial stressors are impacting on the younger individuals too. So I think the emphasis, one of the things that's nice about getting older, for example, Males take a lot longer to ejaculate, so they could engage in intercourse for longer periods of time. I hear that is one of the benefits of the aging part. Now, I think it does complicate post-surgical reactions and so on. Age is certainly one of the factors, as well as alcohol, as well as other drug intake, as well as diet. There's lots of other things in terms of quality of life that impact particularly on the erective distress that we find in men. But there's great opportunity to get closer as a couple. One of the things as couples, what we find is that initially there's some disagreement or some anger. But what you do is if you add years to it, anger develops into resentments. And resentments are very difficult sometimes because then when you get to my age, with couples our age, you see bitterness. And these are couples that don't talk to each other, don't have anything to do with each other. They really dislike each other. That's really that's very hard to unravel in therapy. Where we want is if there's some issue initially, if we can deal with it, then some great things, you see some great things happen as a result of couples dealing with those.
Are there any studies that show that couples that maintain their intimacy, maintain their intensity of the relationship, have a healthier overall quality of life?
Oh, I think that would be true in terms of as couples get older. I think the quality of the relationship impacts significantly on the quality of the sexual relationship too. That's one of the things to assess going into prostate surgery or some of the other the things as we get older is how good is the relationship prior. If it's good, things will turn out much better in the aftermath.
It's a really great assessment for today. Example of like very honestly, if this was a support group for women, we'd probably have hundreds, if not thousands, of women here today. But because it's a support group more for men and they bring their spouses along, not so many.
Women in the family drive healthcare. So if we can maybe inform you, and this is kind of what Dr. Lutz, our foundation is fixating on, raising the level of care for men, maybe to focus on supporting the female so that she can support the man better.
There's a method.
We have some, and we'll give you some information afterwards. One of the things that we're not ready to roll it out, but Michigan Institute of Urology, we are developing these programs, and a lot of our programming that we're headed towards, we haven't finalized. We're not going to get them up and running yet. We have to clear some things, but is using patient advocates. So finding men, women, or wives, men who've been treated who want to be the advocates. And what we just had a group out from Maryland, a large urology group in Maryland that came out to meet with us. And one of the things that they've been very successful with is with their support groups is that they have patient advocates. They call them patient coaches. And they've taken it to another level where they have wife coaches, where they'll actually get wives who are motivated, who want to help other women whose husbands have been through.
Let me just react to what you said, because I think what you're saying is wonderful. I don't have the answer to that, maybe we can give. But in 1940, the president of the American Psychiatric Association went out to AA groups because they were seeing success there that wasn't happening in therapy. And when he came back to the national convention that year, he said what he found that was working for AA was identification, not analysis. That identification, for example, in the groups you're suggesting with the women, with the issues and how to deal with that, and the support, the fellowship, if you would use that word as AA uses it, is very important in terms of dealing with those in family issues. So I think that's a great idea.
No, if we can talk afterwards. We're starting to form this. Literally, I had a meeting this week about this. Also, professor at Beaumont Hospital on the other side of town, and we've through this foundation, we've actually starting to assess within the Beaumont cancer patients, all cancer patients, our ability to treat survivorship. How well are these patients really doing? Not asking them how they're peeing or where it hurts. It's how they're doing emotionally as well as financially too, because cancer treatment, and it's going to just get worse as healthcare changes, can have significant effects Obamacare, but it also will affect your work. Can he still maintain a job? Because the insurance companies or disability insurance, well, he's walking, why can't he work? Well, he has some issues that we can't really quantify, but that will affect his ability to work, but they'll say that won't register. So there's a very complicated process that we're addressing, because one of the big concepts in cancer care now is survivorship. Okay, our treatments have gotten so good over the years that most people will survive their cancer. Most people will not die from their cancer. Okay, so with that in mind, there are more cancer survivors in the U.S. right now than newly diagnosed. So what we see is this huge population of people that probably aren't being treated appropriately. We're missing a lot of things in their treatment, financial, psychological, things like that. With that in mind, and through our foundation, we are going to address that. We are starting to do the analysis to figure out how big of a problem it is and develop programming for that. And we kind of not there yet, but through the foundation and through our passion to help patients, we're hopefully going to have these programs in place. It's just kind of a new concept that hasn't had the time to mature yet.
So I'm Jennifer Nagy with the American Cancer Society, and so we're a mission partner with MIU, and we have been for
Forever.
several years.
Oh, yeah. 7
And
years.
so we're working together, making sure that information is available, resources are connected.
We agree. It's a problem. The American Cancer Society is aware of the problem. It's something that as time develops, that we'll continue to work on. But we have resources. Clearly we have to improve on our outreach.
And we're actually lucky to have Jennifer Nagy here. Jennifer is actually with the American Cancer Society, actually serves great purpose there. And I used to serve on the board at the ACS here in the Great Lakes Division. And what ACS does is that they don't treat one patient. It's somewhat of a misconception. They really don't treat patients, but what they do is they help people. They don't tell you what treatment to get. They just help you get educated. They help teach you about what you need, and if you don't know what you need, they'll help you understand what you need. They serve an amazing resource. They're available 24/7. They have every language spoken everywhere in the world. You pick a language, they've got someone who speaks it. It's a pretty amazing organization, and what they've done and how they've helped, say, the Michigan Institute of Urology, is they have put together specific binders and information packets for every single patient diagnosed with prostate cancer. They have the resources to get more information. So they actually facilitate for you, and they'll keep an eye on you, and that's a really wonderful thing. So it's a great organization, something to keep in mind, and we use them as a trusted resource on our website. So they're one of our links on our website with NCI and NCCN. So I think it's something you should keep in mind. The ACS for a long time felt that prostate cancer, being such a pervasive disease, needed to look at the role of prevention. I think ACS for a long time thought that we should always look at prevention, that if we're going to have a role in this world, that prevention is important. And something that you may not know, that just a few weeks ago it was announced that worldwide prostate cancer is now 1 out of every 4 cancer diagnoses made. And its incidence is continuing to rise. In fact, the incidence of prostate cancer rose 53% in Singapore. And somebody goes, well, why is that? Well, we still believe that there's certain environmental effect. It's not just genetics. And so I guess that gets me into the thought of prevention. If there was something, if there was a thought of prevention, do you, Jason, do you have any concept as to, what we can do as far as prevention of such a pervasive disease? And maybe if you wanted to add something, Jen, along the way?
Yeah. The data on prevention, the classic examples, the National Cancer Institute did a $30 million trial a few years ago looking at vitamin E and selenium, because there was a lot of lay press and a lot of soft data to show that it improved prostate cancer survival. And what came out, this was a few years ago through Dr. Eric Klein, was that it actually didn't help prostate cancer, and now we're starting to see that it actually may worsen the prostate cancer. So prevention, looking at one micronutrient, one pill, is probably not out there yet, and we don't know about it. What I always counsel patients about, the best prevention is being healthy, eating well, exercising, and taking care of your body. It's kind of the simple things. I don't think there's going to be one magic pill or one vitamin Z that's going to cure this. Okay, it's taking good care of your body. You know, a lot of times I'll refer patients to a Mediterranean diet. You know, what should I eat? Well, you should probably eat a Mediterranean diet, a diet full of chicken, fish, 5 to 7 servings of fruits and vegetables a day, a diet that's limited in saturated fats and red meat. Because when you look at those patient populations, their cancer incidence is lower. And the other thing that I constantly tell patients is that, you know, if you look at if you were to plot your disease against your risk of death, you're more likely to die of something else, probably cardiovascular disease, than you are the cancer. So that I think the best thing to do is to have the best cardiovascular health, good diet, a lot of exercise will probably lead to your best outcomes.
A lot of times you talk about, like someone says, Doc, what's the best thing I can do about my prostate cancer? Tell me, how am I going to beat this? How am I going to cure this? And I just say, heart healthy. And they look at me and they go, really? Is that the best you can tell me? It is. I mean, we know that if it's heart healthy, it's going to be prostate healthy. We are actually giving away these books today, and I hope everybody does grab one. It's written by Dr. Mark Moyed, who we're very proud to say is actually on the board of our foundation. From the University of Michigan, is an internationally renowned nutritional supplement expert. And so he's written these books on promoting wellness for men's health, and it's not just for men's health, it's also to help with you with regards to your prostate cancer survivorship. And so I would recommend that each of you take one of these with you today. But we talk about this all the time. It's really getting your BMI down. It's exercising regularly. It's limiting your stress. It's sleeping better. There's been article after article published, even in the last 6 weeks, on melatonin levels being helpful in reducing prostate cancer progression. Exercising 3 times a week has actually dropped PSAs in prostate cancer. Dropping your BMI is actually shown to diminish PSAs and improve recovery. I mean, it's amazing that really that's what it's all about. So if you're trying to figure out if you're doing the right thing, if it's heart healthy, it's going to be prostate healthy. Also disconcerting to me is I had a fellow the other day, we talked about this, about how his wife has become a food Nazi. And so that is also the other extreme. We don't want to have happen there. You have to set kind of like guidelines and rules, and that's maybe where Dr. Petrofessa comes in and helping through the counseling phase, because it's really important to do this together, because that's everybody wins if you do it as a team.
Now, you've had a question for a long, long time, and
I actually was invited to speak at Ford Motor Company, and they put it out to all of the employees at Ford Motor Company. We were able to get 47 people there.
Right.
It's extremely disheartening, but it's really hard to get men to be engaged about their own advocacy.
So what we envision, or what we're headed, is to develop these patient coaches, or these patient coaches, which are survivors, to incorporate, and we're just looking for guys to facilitate other patients. There'll be some physician involvement, but a patient facilitator who's been through it, who's worn a pad, who's, has been in the hospital bed and has lived through a lot of these treatments, and to develop a network like that, as well as a partner support group too. What I do in my practice, I keep a list of patients that I've treated, guys who are very motivated and good speakers and are passionate about the disease, where I'll say, call John or call him, you'll like him, and he'll explain to you what to expect. Because you're right, I don't know this stuff. I haven't walked in those shoes. I know, technically what I have to do and what the science says to do, but I don't know that. And that's why I kind of rely more on previously patients who've gone through it, really. Because there's little things that I don't know.
Just to fast forward 6 months, Karen Giltru, who's here today, is our clinical cancer care coordinator for the foundation, and she has a phone number that can be reached, 1-855-66-HELP-MEN, and we are developing that network that you're talking about. That is our goal, is to develop an advocacy network of people like yourself and other individuals that have gone through cancer, and spouses of people who have gone through cancer, so that there'll be a resource network for people to speak to have these conversations moving forward. because it's not really being done adequately, and it's definitely not being done adequately within our organization and within what we believe is in our community. And so we'd like to take that leadership role and use our resources to do something just like that, because that's our goal, is to enhance survivorship for the families.
That we did have a program. It was called Man to Man. It was a nationwide program that we did train men that could speak to other men who were prostate cancer survivors, and we did have group settings similar to a support group where you could come in, talk in a group setting, share, have a medical speaker come in and talk to the group if needed. What we found is that the attendance wasn't there. Men weren't coming to the groups. And so as a nationwide trend, that wasn't helping and that wasn't fixing the solution. And so now we're finding ourselves partnering with larger groups, figuring out what is needed now, what can we do different. And so it's interesting and it's great to hear that it's needed, but we don't know if it really is truly needed. It might be needed for one individual, but I don't know if it's needed for everyone. And so that's what we're trying to still figure out. And so having these kind of lecture series right now gives us the opportunity to get feedback, but it also gives us the opportunity to partner and seek additional opportunity. And so I think at this point, what MIU is doing is the first step of something different and unique for us to try, and their online resources are there. There are support groups that are available in the community. And so I don't know how you linked where you linked. I want to make sure you get connected to the American Cancer Society. I want to make sure you get connected because many churches offer a support group. And so we have those resources listed in our database. And so I do want you to get what you need. And so that's why we're connecting here.
I hope that more positive than negative comes out of this, not only for you, but for everybody here. I hope that if you have a comment or something you think that we should do that you think would make it better, feel free to fill it out on the cards. Make sure you leave us your email address so we can reach out to you down the road. Understand that, as I said, this is a process. This is not a definitive series that's going to stay like this forever and ever. We're looking to make it better for you, not only for the prostate cancer patients here or with us today, but also for those individuals who are the survivors and for your families. We hope that you'll partake in things that we do down the road and join us in our foundation and our Fight Like a Man events around for the Detroit area and across the country and in the UK and Canada. We are partners through our foundation with a collaborative where we're doing services looking at prostate cancer survivorship. There's questionnaires that are on your tables. If you're interested and willing, we would appreciate that. If you fill those out, we can take care of them from you today, or you can mail them back to us or to Karen. And we're sending them on to our researcher at the University of Central Florida looking at environmental, lifestyle, and behavioral effects that might affect prostate cancer survivorship down the road and trying to look for linkages. And as well, don't forget we have these books that are available for any one of you. It's really wonderful on nutritional aspects of prostate cancer from today and looking beyond. And we just appreciate your attendance today, and thank you so much for being here. And thank you to Dr. Heffer and Dr. Petrofessa.